Hello, I'm Helen Zorbas, and it's my pleasure to welcome you to this breast cancer education series produced by National Breast and Ovarian Cancer Centre in collaboration with the Rural Health Education Foundation. We're delighted to have you as health professionals in rural and remote areas of Australia joining us for this program focusing on breast cancer care. In Australia, approximately 30% of women diagnosed with breast cancer live outside a major metropolitan city. As well as their cancer diagnosis, these women face additional challenges, including geographic isolation and limited contact with specialist healthcare workers. As rural health professionals, you have a vital role to play in both the provision of information and the delivery of best practice clinical and supportive care for rural women with breast cancer. We hope that through this series we improve your access to evidence-based information and ultimately benefit the women with breast cancer in your care. The program has been developed to be specifically relevant to rural practice, and I would like to thank our facilitator, Dr. Norman Swan, and the breast cancer experts and rural health professionals who have contributed their time and expertise to this broadcast. I hope you enjoy the program.
Thanks to Helen Zorbas, the Chief Executive of the National Breast and Ovarian Cancer Centre, and welcome to the programme on secondary breast cancer, finding breast cancer outside the breast. This is our joint initiative, as Helen just said, with the National Breast and Ovarian Cancer Centre and the Rural Health Education Foundation. It's also a project of the Supporting Women in Rural Areas Diagnosed with Breast Cancer programme, and it's funded by the Australian Government. Now, most women who present with secondary or metastatic breast cancer will have already been diagnosed with and treated for early breast cancer, although for some this will actually be how they present. Today we're going to consider some of the challenges in looking after women with secondary breast cancer, recent developments in treatment, and the psychosocial and supportive care needs of women and indeed their families. You'll find a number of useful resources available on both the National Breast and Ovarian Cancer website, nbocc.org.au, and on the Rural Health Education Foundation's website, rhef.com.au. I want to introduce our panel to you. Tony Hobbs is a rural general practitioner from Cootamundra in New South Wales. Welcome, Tony.
Thank you, Norman.
Jane Ingham is Professor of Palliative Medicine at the University of New South Wales and is also at the Cunningham Centre for Palliative Care in Sydney. Welcome. Chris Keogh is a clinical nurse specialist in palliative care at the Mercy Care Centre in Young in rural New South Wales. Welcome, Chris.
Thank you.
Chris Milross is head of the Department of Radiation Oncology at the Royal Prince Alfred Hospital in Sydney. Welcome, Chris.
Very happy to be here.
And Nicholas Wilkin is Director of Medical Oncology at Westmead Hospital in Sydney. Welcome, Nicholas.
Hello.
Welcome to you all. Now, before we start our discussion, let's hear briefly, because we want to be really as focused as we can on the woman's journey with breast cancer, and hear from Judy, who has metastatic breast cancer.
1993, breast cancer sneaked into our lives like a thief in the night. Lloyd, Oliver, Kyle and Tara, my greatest wish was to see you grow up. Grow old with your father, sit on the veranda surrounded by grandchildren. I never wanted our lives to change. We moved to the country and hoped we'd left breast cancer behind. Cancer returns to my body, to lung, bone and spine. My breasts are gone, breasts that nurtured 4 children and gave pleasure. In their place, a tapestry of the scars and wounds of the last 12 years. I struggle to make sense of my life. I hold back the pain and the tears buried so deeply, feeling dead, dry and hollow, ready to splinter.
Thank you to the Breast Cancer Network of Australia for providing Judy's story. Tony, unfortunately, not an unusual story.
No, it's not, but it's not one that we often see in general practice, Norman, and I think that's a really important message tonight. Even though metastatic breast cancer is not going to be a common presentation in general practice, we need to think about it in women that present with new or different symptoms that have had breast cancer in the past, and help them navigate their way forward with a good management plan in place, working with our specialist colleagues, and to make sure that we bring a message of hope and support not only to the woman but also to their family.
Chris Keogh, I mean, it does illustrate, though, the support that such a woman and her family need.
Yes, it does, and it's probably important for these rural women that can be quite isolated as well. So there are supports around in the country, and it's important to work, I guess, with the GPs and as a team with the families to help these women at this time.
We'll come back to more of these themes later. Nicholas, of all women with breast cancer, what proportion does it come back?
It's difficult to get really accurate figures, but broadly speaking, around about 20% of all women with an initial diagnosis of breast cancer will ultimately get a recurrence.
So 80% are cured?
So 80% do not in their lifetimes get a cancer recurrence, and we sometimes forget that when we concentrate on metastatic disease.
And is that proportion getting lower?
It is getting lower as our screening detects cancers early and our adjuvant treatments work better. We are finding fewer and fewer women developing metastatic breast cancer or secondary breast cancer, and also that where it does recur, it's starting to recur later and later.
And what's the pattern over time?
So over time we still mainly worry about the first 5 years. I think there's a graphic we're about to see that illustrates that, that we'll see in the first 5 years that the risk of recurrence is highest, but it never goes away. And if you have a look at that graph down at the 10-year mark, you'll still see that maybe 0.5%, 1%, 2% a year women are getting recurrences. And at that point, 10 years down the track, it's mainly the women who initially had hormone receptor positive disease who are at risk very late on.
And what are the risk factors for recurrence? Can you predict who's going to get a recurrence?
You can to an extent, although it's an imperfect science, but essentially the risk of recurrence depends on how bad the disease was initially, largely measured by how big the tumour was. Whether it involved axillary lymph nodes or not, and if so, how many, and then certain aspects of the biology of the tumour, high grade versus low grade, hormone receptors there versus not there, and increasingly, of course, we're interested in HER2 positive disease as well. So you can put together a kind of a nomogram with that information that will broadly estimate for you the likelihood of recurrence, and of course, based on that, we will recommend or not recommend certain adjuvant treatments that will potentially prevent or delay that recurrence.
And is there any way of predicting in a woman which organs she may be liable?
Look, only very broadly, and that is that the lower grade hormone receptor positive cancers have a predilection for recurring late, as we said, and also recurring in bone. So the scenario of widespread bone metastases but no metastasis elsewhere is very typical of hormone receptor positive cancer. Hormone receptor negative cancers tend to more recur in the viscera, and HER2 positive,
so that's liver and lung
in particular, and HER2 positive breast cancer has a particular predilection for brain metastases.
And Chris Milross, women and their families want to know the prognosis. It's come back, they want to know the prognosis. How accurate is the dark art of prognosis in recurrent breast cancer?
I think the honest answer to that question is that the dark art of prognostication is probably not very accurate. But there are a range of scenarios. The outcome for the woman diagnosed with metastatic breast cancer is perhaps best in the context of a woman who's had a long disease-free interval, so 5 years, 10 years, even 15 years from treatment for the primary cancer through to the presentation with metastatic disease. The pattern of that metastatic disease at presentation, together with the features of the primary cancer that Nick mentioned, also influence prognosis.
So fewer secondaries and less disseminated.
Long disease-free interval, bone-only secondaries, previous hormone receptor positive disease, those things all portend a better prognosis. And shorter disease-free interval, high-grade disease, triple negative disease, and the prognosis is more problematic.
Local recurrence secondary breast cancer? And is contralateral?
Look, you probably say no, because I think when we say, there's always a grey zone in these classifications, but when we say secondary or metastatic breast cancer, what we're saying is that is recurrence away from the breast, chest wall, axilla region, such that although, as we'll see, there are multiple treatment options, that disease is ultimately incurable. I think that's the basic definition. So were a woman to get a recurrence in the breast, if she hasn't had a mastectomy, or the chest wall if she has, that is a potentially salvageable and curable situation. If a tumour is found in the other breast, it may or may not be a second primary. So again, that's a potentially salvageable situation.
So it's all over again. What about surveillance, Tony? What's your practice in terms of following? So a woman's been treated for early breast cancer, she's now on she's not on any treatment anymore, she's had her adjuvant chemo and radiation, and she's just been followed through. What surveillance do you routinely practice, and what do the guidelines say?
Well, I think there's a couple of issues here. The first is that you need to make sure that the woman is comfortable with having her surveillance with her GP. Some people wish to continue seeing our specialist colleagues, the oncologist or perhaps the breast surgeon, on a regular basis. And interestingly, the NBOCC, the National Breast and Ovarian Cancer Council, is actually doing a trial in 4 centres about this at the moment. Certainly the evidence around surveillance is to offer the woman who has survived breast cancer regular follow-up. So in the first 2 years, coming back every 3 to 6 months to take a thorough history and physical examination. In the next 2 years, every 6 to 12 months, and thereafter every year, and you can see this on the follow-up schedule. It's really important that each of these women have a mammogram and or an ultrasound, depending on their age, every 12 months, but also to make sure that we don't do any other investigations unless there is good symptomatic suggestions that there may be a recurrent disease somewhere, and that's pain or some other change.
Nicholas, is there any evidence that early detection of recurrence changes outcome?
No, there isn't. In fact, the converse is true, that as much as it has been looked at so far, trials of very intensive surveillance have not shown to be beneficial, might be actively harmful, as opposed to what we just heard from Tony. And the two problems with doing the kind of imaging that we have available to us, other than mammograms, are number one, that any abnormality that you find in an asymptomatic woman is probably likely to be a furphy, and so you've created a whole lot of anxieties and extra tests that need to be done. And secondly, as you implied from your question, this is ultimately incurable disease, often slowly evolving, and finding those lung metastases or whatever they are in month 1 as opposed to month 3 or month 4 does not make any difference.
Jane, given that we're talking about end of life here, but end of life might be 10 years from now, but it's still it's kind of an end of life diagnosis. Are we still seeing too late referrals that are too late for palliative care, where they could be helped by being seen earlier?
Well, it depends whether you refer to palliative care as a palliative care specialist or a team of people who are addressing your palliative care needs, some of which may be your psychosocial concerns, your anxiety, your worry, your fears. Others may be symptoms. And I think if a GP, particularly in a rural setting, and a community nurse and an oncologist who's at a distance or intermittent visits are addressing that spectrum of needs, then I think there doesn't necessarily need to be a referral to palliative care. That said, if the symptoms are difficult to control or the psychological concerns are worrying and out of the usual realm or out of the skills of the GP with regard to managing them, I think that's the time to call a specialist. But palliative care can play a big role throughout the course of illness depending on the patient's needs.
Chris Keogh?
Yeah, certainly what Jane said is true. I think people like this will move in and out of palliative care as the need arises. If it's a more complex problem that they may have, then certainly palliative care might be involved in that, and then referring back to...
Tony, do you think people recognise that palliative care does not mean that you're going to die next week, and that this is about complex symptom management and helping you out, or is that still a, if you like, a stigma or a problem with the name palliative care?
I think there are misconceptions both from the people in the community but also among some health professionals about the role of palliative care, and I would certainly strongly endorse what both Chris and Jane have said about using the team but about having the conversation with the woman involved and her family early in a structured, supportive manner, and making sure that they understand what palliative care is about. Some people will choose to engage early, some people won't, and we need to ensure that people have the information to make an informed choice.
Let's go to our first case study, who's Leah. She's 62 years old, or young, and lives with her husband on their farm. She's involved working on the property. She had node positive, ER positive, estrogen receptor positive early breast cancer about a decade ago, and was treated with lumpectomy, chemo and radiation therapy, followed by tamoxifen for 5 years. She's come to see you previously, Tony, with aches and pains in her right arm and chest, and has limited mobility in the right side. You sent her to physio. There was some improvement in her symptoms, but she's back again, and now there's a bit of upper back pain. It's worse at night, wakes her up, worse when she's using the computer.
Well, this is a potentially not uncommon scenario, in that we have a survivor from breast cancer who's been treated quite some time ago, that you've had an ongoing relationship with them, that you know the particular person well, and you've probably got a relationship with the rest of their family at some level as well. So it's in that context that she comes with quite a new symptom, pain, which is different from her previous pain related to her surgery and or radiotherapy. It's in a different site, it's keeping her awake at night, it's worse with movement. That would raise red flags for me as her treating GP, and we would need to have a discussion about whether or not this might be metastatic breast disease, or in fact whether it might be something else, like a muscle strain perhaps, or perhaps even an osteoporotic fracture in someone of this age. So it's really important to have that discussion up front, not to alarm the woman, but to say that this could represent metastatic disease, and then have a management plan with her about how you're going to move forward. And that may be investigating that early with an X-ray and or a bone scan. It may well be having a conversation with the previous treating specialists at the regional centre, but to make sure that the woman understands that you're going to be with her, that you can have a plan in place both to investigate and, if necessary, treat should the diagnosis be confirmed.
Is that your script, Nicholas?
Yes, I think so, and I think it's at what is potentially a difficult time for the woman, good for her to know that the GP is concerned about the possibility of recurrence, is going to do some imaging and has contact with the initial treating specialist, so that the woman, although she's going to be very worried, at least can see a kind of a linear progress of what's going to happen. And the initial contact, we would hope, from the rural GP is to be able to contact fairly directly the oncologist, medical oncologist, radiation oncologist, whoever it is, so that if it turns out that she needs to come to some bigger centre for either assessment or treatment or both, that can be done fairly quickly.
Why does it need to be done quickly?
It needs to be done quickly from a psychological point of view. If she's got severe pain, it may need to be done quickly. But from a purely medical point of view, if there are no obvious complications, and it does turn out that this is a bone secondary with some pain that's perhaps controlled with some Panadol or Panadine, then there's no medical urgency, but there's usually, if this is the first diagnosis, a pretty serious psychological urgency.
So, in a sense, was Tony wrong to have delayed this? She already had symptoms on the right side, now she's come back with upper thoracic pain, he sent her off to the physio. Should he have responded earlier to this?
Absolutely not, and there's actually two interesting points there. One is, which is tricky for all of us, GPs and specialists alike, is women who've had treatment for breast cancer and surgery and radiotherapy often have non-specific symptoms on that side that are tricky to sort out, and often you've had the third or the fourth complaint, so you might actually trigger a bone scan in that setting, which will turn out to show nothing. And what Tony is responding to is a new symptom that has persisted and has got worse. So that's when you investigate, and investigating beforehand is just going to lead to a lot of furphies.
Chris?
Breast cancer, previous breast cancer doesn't protect you from the aches and pains of ageing and life. Tony's not wrong at all.
Did you want to say something, Jane, about this?
No, but I think when you have any symptom, it's important to look at the symptom in terms of its etiology as well as to how you're going to treat it. So assuming Tony's gone through a thought process, which I'm sure he has, about what the cause of the right arm pain is, that may have been present for years, came on immediately post-surgery, and detected that there's something new, and has in his mind a pathophysiology for that first pain, as well as the second pain, then that's the way to think it through, and there's no problem with that.
But if there's no, biologically, if there's no urgency here, early detection, we've already agreed that early detection of spread is not going to change the outcome. That can be quite hard to explain to somebody post hoc. You know, if you decide, well, we're not sure what this is, but I'll send you off to see the physio and I'll see you in a couple of weeks.
Well, I think it's important.
The word's going to get around town. You know, he missed the fact that it had spread.
I'm quite sure that I defer a little to Tony and how he deals with that, because that's something that I don't deal with commonly. But there are ways of communicating that information.
And it comes back to Tony saying that usually in the rural setting, this is someone you already have a relationship with. And if it turns out that it is someone who is always exceptionally anxious, well, sure, you may end up doing some more early, more bone scans than you otherwise would have.
Can I say, I think there's a really important message here, that remember this is an individual patient sitting with us, and I agree with what Nicholas has said. We will respond according to the situation. So you might have someone who's really anxious, you might have someone who's very relaxed and very happy to wait. And really,
the issue is transparency, being honest with them.
Absolutely.
And setting up a clear plan, I think, so the patient feels confident, as Nicholas said before, that the team is involved and there's a stepwise plan to sort this out.
Now, a woman in this situation, Chris Keogh, people say requires support, as indeed she does. But what does support actually mean? You know, we talk about psychosocial support, we talk about psycho-oncology. In a rural town, in a country town, what does support actually mean? What do you think she needs that she's not got from the conversation we've just heard with Tony? Well, she hasn't even got a diagnosis yet.
No, that's right. That's certainly right. And
which reminds me.
But I think it is important to give these people support coming from a community nursing background.
What does it mean? What does it
to
look
actually
like?
To go in, spend time, listen. Sometimes there might be other issues going on at the time. The family might need some extra help. She may be not coping well with this, pain, even in the basics of, housekeeping or things like that. So that early referral to other services might be appropriate at this time, even though she hasn't got that palliative care sort of diagnosis
So,
yet.
Nicholas, Tony's on the phone to you, asking for advice about what imaging or what diagnostics would be most appropriate. What are you going to say?
I think, as Tony said, if we're worried about what sounds like the thoracic spine, it's probably reasonable to get some plain X-rays. And unless they're completely and absolutely normal, you're probably going to proceed fairly quickly to a bone scan.
Well, let's have a look at Leah's bone scan, because that's in fact what she had. Chris?
Leah's bone scan shows numerous foci in ribs, in a pattern typical for bony metastatic disease. And then if we take a look at the next image, which shows us the thoracic spine in more detail, you can see activity in the 11th thoracic vertebral body taken together, a pattern highly suggestive of bony metastatic disease.
And Chris, would you go on and do CT and look for metastases elsewhere?
I may, under certain circumstances, because of one of the most serious consequences of a metastasis in a vertebral body, which is compression of the spinal cord. So what specific circumstances would drive me towards further imaging? Severe pain and certain neurological symptoms, Norman, including a radicular pattern to the pain, sensory disturbance in the lower limbs, a feeling of unsteadiness or frank weakness, and or bladder and bowel symptoms. Those sorts of things taken together would make me worry about the potential for spinal cord compression, and I would definitely want more than just an X-ray and a bone scan.
And would you be looking at the liver and lungs, Nicholas?
I think there are probably two phases of investigation here. The first is the rural GP determining whether this is a non-specific ache and pain, an osteoporotic fracture, or indeed metastatic breast cancer. And for that, as Chris has just said, we want a plain X-ray and a bone scan, and if there aren't any neurological concerns, probably don't need any further imaging. That gets us a diagnosis and we move on to treatment. after we've, as we'll come to discuss, after we've essentially calmed things down, there's probably a role in doing a CT scan then, because this woman is now starting what hopefully will be a very long metastatic journey, and it's probably not unreasonable right at the beginning just to establish if there's any other disease that we have to know about, but not in terms of the initial management.
So treatment, radiotherapy for this, or chemo?
Radiotherapy for this local T11 problem, with the aim of palliating the pain that's present now and preventing progression of the metastasis in that site, and ultimately the development of neurological consequences of that. So yes, radiotherapy, but radiotherapy as part of a more general approach to the pain.
And what about if she's got other lesions elsewhere? You wouldn't treat those, you just leave them be if they're not causing problems?
We wouldn't treat them with radiotherapy, but having made a diagnosis of metastatic disease, we would address those other lesions with a systemic agent.
So this is where bisphosphonates come in, Nicholas?
And yes, but more importantly, endocrine therapy. So this is the pattern we mentioned before, where her disease has come back 10 years down the track. The original disease was hormone receptor positive, and this is highly likely to be hormone receptor positive disease. So there's no immediate indication for chemotherapy. It's very likely that the rest of her disease will come under control with some endocrine therapy, like you could try tamoxifen again, or probably an aromatase inhibitor. And then yes, there is a role for bisphosphonates.
I thought they help prevent spread to bone.
That's a controversial issue. They may, but the main indication for bisphosphonates in this setting is that they've been shown in a number of trials to minimise the risk of fractures and to help with pain and to reduce the future need for radiotherapy.
And do they have to be given IV because you've got the risk of the osteonecrosis of the joint?
You have. From a rural setting, there are potent intravenous bisphosphonates that only need to be used every few weeks, and the risk, at least over the first year or so, of osteonecrosis of the jaw is extremely low. But there are also effective oral bisphosphonates. Clodronate has been shown in randomised trials to be helpful for women with metastatic breast cancer. And if it's a woman who doesn't need to have chemo, so she's going to have an endocrine therapy tablet, then it would be very reasonable for that woman to be on oral clodronate so that she doesn't need to be tied to a cancer centre.
What about metabolic problems such as hypercalcemia, where you get extreme fatigue, flaccidity and that sort of thing?
So hypercalcemia, because we use bisphosphonates, is not nearly as common as it used to be, and is generally seen in a woman with heavy multiple bone metastases, more than what we saw on that bone scan, at a time when her disease is progressing. So certainly a woman with known bone metastases, a story of getting sick, being nauseous, pain worsening. There are other things that could be happening. She could be developing liver metastases, but a set of bloods that includes liver function tests and calcium would be in order.
And what's the course of radiotherapy? Say you were just treating the thoracic. I mean, how many weeks? How many?
Palliative radiotherapy courses are typically very short. So for a bone metastasis such as this, where we are satisfied that the bone has solid structural integrity, then a palliative course of treatment might be as few as 5 fractions or even a single fraction. In fact, the two options have been compared in a number of randomised trials and shown to produce, at least initially, equally effective palliation of pain. For a rural patient, my personal bias is generally to give a slightly more protracted course of treatment, because the one potential advantage of that approach is to reduce the likelihood that the same area will need to be subsequently re-irradiated.
So you just sort of steel belt it?
So if you're going to bring a person from the country to the city for radiotherapy treatment, you do it once instead of having to do it twice.
Nicholas, just give us a quick cook's tour through the symptomatology that a general practitioner needs to look out for in the broad for metastatic breast cancer.
Again, the key is a new symptom that persists and gets worse rather than better. We've seen what happened to Leah with new back pain that got worse. In terms of visceral disease, fatigue, a general difficulty in coping with the sort of frenetic pace of the day, maybe some right upper quadrant tenderness, being a little bit off the food, a bit anorexic, maybe a bit of weight loss. if the liver function tests are completely normal in that setting and there's nothing to feel in the right upper quadrant, it's unlikely that there's a significant load of liver metastasis. There could be something subtle, but there's unlikely to be anything to be immediately worried about. And I guess in the era where our systemic therapies for initial disease are working better and better, so women are living longer and longer, we are starting to see occasionally, more than we used to in the past, brain metastases. So feeling sick every morning, headache that's not going away, or some kind of neurological symptom. Again, most of those things are not going to turn out to be brain metastasis, but that's the sort of thing where Tony probably does have the conversation. Look, I'm a little bit worried. Let's get a CAT scan.
Occasionally, an optometrist will pick it up with a retinal deposit.
Yeah.
And presumably the investigations you do are common sense, Tony, investigations that arise from the symptoms that you're seeing, rather than jumping to a CT pulmonary angiogram with everybody you see with a cough.
Look, that's true. Once again, it's about this individual patient and her symptoms and treating those appropriately with a plan in place. So not to jump to a conclusion, but to take things forward stepwise.
Although it's easy to forget that thromboembolic disease is a lot more common in this group of women.
It is, and indeed, if someone turned up in my practice that had had breast cancer in the past with dyspnea, perhaps pleuritic pain, maybe a bit of a cough, you would investigate that appropriately over a period of time, and that would be chest x-ray, maybe an ECG, and always thinking of the diagnosis of pulmonary embolism and maybe using a scan or a CT pulmonary angiogram.
Chris Keogh, what are the range of psychological reactions that a woman gets at this time when she's now been told that, although her worst fears are confirmed, that the cancer has come back?
Sometimes these women can be quite angry, not really understanding why that's happened, when they've understood that some of the treatment, or the treatment that they've previously had, is curative treatment, so they can be quite angry about that, or just generally anxious and concerned what's actually happening with them and where that sort of journey's going now.
What I want to talk to you about now is just there is a guide for women with secondary breast cancer to help understand their diagnosis and treatment options. This is an updated guide based on the clinical guidelines, and it's available free of charge from the NBOCC, and that's nbocc.org.au, I think. So Leah's bone scan confirms bony metastases, and you develop a management plan for her based on this, and you wouldn't jump into chemo here if there are no other...
No, and the key points there are, it's been a long time since her primary disease, so we expect the outlook to be better than average, that it's a hormone, that the primary cancer was hormone receptor positive, and not always, but probably 85% of the time that persists in the metastatic setting, and also that, as far as we know, the disease is mainly in the bone. So they're all things that would suggest that she probably respond well to endocrine therapy, and that we can save up chemotherapy for a time when we more need it.
How long would you expect to get a pain response, an analgesic response to the radiotherapy?
It's a very good question, and it's an extremely individual finding. Some patients will have an improvement in their pain after the first fraction of treatment. Some patients will need a week or two beyond the end of the course of the radiotherapy to get an improvement in their pain, and everybody else is somewhere in between the two. Generally, the pain will improve during the course of a palliative radiotherapy treatment for bone metastases.
So what's your approach to the treatment of pain then in Leah?
Obviously, on the day that the decision's made to give radiotherapy, there'll be no response to the radiotherapy. It would take us a day or two or a week to get that thing organised, so we need to start with some analgesia in the meantime.
So what would you do, Tony, before she's going to get her radiotherapy in 2 weeks' time? What are you going to do for her in terms of her pain?
Well, it would depend how severe the pain was and what I thought was actually causing the pain. So you would build on perhaps simple analgesia, paracetamol, anti-inflammatory agents, for instance, but you may need to either at that time introduce opiates, for instance, or even other medications, depending on the pain. And indeed, if you thought there was radiculopathy at the time, I might well have a conversation at that time with either the regional oncologist or perhaps even ring someone like Jane, a palliative care person, an expert in pain control, just to get another opinion about how best to meet her pain needs. Clearly, that's important while we're waiting for the more definitive radiotherapy.
I assume the risk here, Chris, is that you dive in too low and don't capture the pain and actually deal with it with the heavy guns, with the guns that are heavy enough to deal with it at that time, and that's a matter of judgment. But I'm talking about the pharmacological treatment of our pain and the risk of low rather than just getting rid of the pain.
Well, I mean, I think that the medication that you choose to deal with the pain is exactly driven by the severity of the symptoms, and we've got a large armamentarium and a WHO pyramid that demonstrates the hierarchy, if you like, quite well, but mindful of the fact that we don't necessarily move from simple analgesia to more complex analgesia. If it's a serious pain, we'll start with the serious analgesia.
Jane?
Yes, and I would usually emphasise to patients that this isn't this is something that we have to work with them, possibly intensely over the next few days. When you start a treatment, you can't always predict that it's exactly the right treatment for that patient because everyone's pain is individual. Encourage the woman to be following up if the pain management you started today is not working. Encourage the person to come back to the GP and say, brought the pain from 7 to 5, but it's still not at 3. And also the other thing I would add to it is that then, aside from a pharmacological approach, there would be a physical approach that might address the woman's activities in the setting of this bony metastases and suggest that perhaps some activities might not be optimal this week and that some activities might hold back on until we got the pain better controlled.
Chris?
One other thing that I don't want to forget to mention in the context of a person with a prior diagnosis of breast cancer just discovered to have bone metastases, we were talking before about would we target treatment to other sites. We need to remember the long bones because if there'd been abnormalities in humeri or femora that were at risk of fracture had they been assessed, then those locations certainly would be treated preemptively.
So I think that's another really important aspect to pain management too that we have skirted around a little bit, and that's the psychological support for the patient and her family as well. If we can validate, fears, listen to them, and help them in a supportive manner, whether that's the GP in isolation or whether it's the broader team, the palliative care nurse, for instance, the specialist. I think that's going to be really important in helping to abrogate and lessen that pain as well.
Nicholas, given that the standard of care here is multidisciplinary team-based care, in other words, radiation oncologist has to be involved in this situation, psychologists, there's psychosocial support, not to mention the general practitioner, and it's hard in country towns because you don't have the stuff you've got in a major metropolitan centre, the resources. What's your approach to multidisciplinary team-based care so that women from country areas get the same sort of standard of care as women from the cities?
So I think, the dry academic answer would be that there are studies that show that multidisciplinary care matters, that it improves outcomes, but that we don't know for sure exactly what component of multidisciplinary care that is that's doing the job. As a clinician, anecdotally, I think that the fundamental critical thing is communication. So Tony doesn't have to be in the same room as I am. I mean, it might be nice from time to time if he is, but he doesn't have to be. But if we know each other and we've had previous experience with patient care and there's a direct line of communication, that is the most critical thing. And similarly, I don't necessarily need to be in the same room as Chris, although I should know him and bump into him from time to time, but as long as I know how to get to him...
He's bunkered down.
Yeah, as long as I know how to get to him. And I can say, look, I'm just ringing you because there's someone coming from the country who sounds like they're going to need radiotherapy sooner rather than later, and I'm flagging a warning, then for this case, that is multidisciplinary care. And the second component of it is when that person leaves the hospital, and goes back to the country, it's vital that
it's not a scribbled
the GP,
discharge summary.
exactly, that the GP gets some intelligible communication. Now, there may be other, more nuanced or more complicated cases where you do want a number of people in the same room, but I think it's all about communication.
What's your practice, Chris?
I was sharing earlier that at a recent panel discussion, Tony mentioned in this sort of scenario that the problems that rural GPs have with accessing the specialist. How do we form a multidisciplinary team if the rural doctor responsible for the primary care of the patient can't find us in order to get urgent radiotherapy treatment or a change in the systemic management? I think the issue for us is one of availability, and in response to Tony's criticism, constructive criticism, I certainly started adding my telephone numbers, both office and mobile, to the end of my letter after country clinics, so that the number's there, and that really does mean we want to be called.
So it's reassuring in that sense. And, Nicholas, Chris, what are the treatment goals you tell women in this situation?
Obviously, it's going to vary from disease to disease and from person to person. I think the first thing is that the woman needs to be reassured that we know what's going on, or we're going to do some tests to find out what's going on, and then there are treatments we have to help. If we're talking about more long-term goals, the goal is to try and get you as much back to normal as we can. You need to know that there is a spectrum of outcomes here, but it is certainly possible that you may be well and alive for some years rather than just months, even though you've got a metastatic diagnosis.
The other source of variation from city to country is a very important source of improved outcome, which is access to clinical trials. The evidence is that if you're in a clinical trial, you do better, even if you've got the comparator treatment rather than the new treatment. What's the access to clinical trials like for women in country areas? Chris Milrose? They'll often walk in and ask for them because they've been on the internet and they've been to clinicaltrials.gov and know what's available overseas.
I think it's a good point. The only, comment that I would make is that it may be a self-fulfilling prophecy in the sense that women who are selected to participate in clinical trials or who seek out clinical trials may have a slightly different, somewhat more favourable cancer. But let's suppose it is actually due to the trial and or the level of involvement with the care team that is inherent in the delivery of a trial medication or the follow-up of a trial patient. I think that these days there is good access to clinical trials through the regional cancer centres that operate. I suppose that would always be true for fly-in, fly-out service, and I'm sure that it's increasingly true for the established regional cancer centres. And then patients who need to travel to the city for treatment have got exactly the same access to clinical trials as the patients.
But increasingly they won't be with new regional cancer centres coming on stream. They'll be treated locally. Yeah,
I should say though that in all the planning for those centres, the importance of clinical trials and support to conduct clinical trials has been acknowledged as being an important component of the design of those centres.
But we also have to probably acknowledge that it is going to be always difficult, and the level of access is likely to be less, and that's something we do have to acknowledge.
And increasingly there's clinical trials in palliative care, Jane?
Increasingly we are investigating the best possible strategies to manage symptoms, which can be seen as challenging when you're caring for a very ill population who may or may not be interested in participating in clinical trials. But we do see that as crucially important because we see this time of life and the quality of life during this time of life very important. And so the more we can understand about the best possible strategy to relieve symptoms, the better for the patients.
Tony, what are you on the lookout here for urgent? We've heard this is a non-urgent situation, apart from maybe if there's compression here, but it's more to actually not allow the woman to fester and be psychologically upset by the fact there's a delay. But what are we looking for in terms of urgent red flag signs here in a woman like Leah?
Urgent flags me, first of all, would be severe pain and getting that under control, because pain is a medical emergency, so that would be my #1 priority. And as I said, I might need to enlist the help of my other colleagues. #2 would be, particularly with this metastasis, would be the risk of having spinal cord compression, and that's really important. So, and we talked a little bit about what that might look like. It might be expressed as sphincter disturbance, a bowel or bladder change, maybe radiculopathy, or even just a sensation of radiation around the trunk. During the course of treatment, it may well be sepsis, so fever or blood pressure changes, change in mental status, for instance. And clearly there are other circumstances that may alert to the risk of a secondary somewhere else. So, for instance, it could be something happening in the chest. It may suggest that the patient may have a pulmonary embolus, for instance. So dyspnea, pain, cough, those sorts of things are really important. And less likely would be the suggestion that the patient could perhaps have brain metastases. So, and Nicholas spoke about this beforehand, headaches that are unusual, nausea, vomiting, perhaps personality change. And the other risk, of course, may be if there are a lot of bony metastases, or in fact, in response to treatment, the risk of hypercalcemia to be picked up earlier. So polydipsia, polyuria, excessive thirst, urination, constipation, perhaps changing mental status, those sorts of things. So they'd be the things that, as GPs, we should be looking for. Nicholas?
I agree with that, and I think it's just worth making a couple of comments about the issue of sepsis, because it's different when the patient is on chemotherapy. So if the patient is on potentially myelotoxic chemotherapy, and not all chemotherapy is myelotoxic, the critical issue is what is the white cell count. Because if the white cell count is low, if the neutrophils are less than 1, then these people can get very sick very fast, and you're better off over-treating them for their infection, admitting them to the local hospital, starting antibiotics before you've got any cultures. If the white cell count is not low, then you can treat it on its merits.
Results.
I beg your pardon?
You mean before you've got culture results?
Yeah.
You want to get cultures, though.
Sure. But if the white cell count is not low, then you can treat the sepsis on its merits. It might still be a serious problem, but you can treat that person like you would treat anyone else with sepsis. So the white cell count, if you can get one, urgently is the critical point.
And can I say here, I think communication again is really important. So my expectation would be if one of my patients was having chemotherapy which might drive a neutropenic situation, I would expect that would come as part of the information back from Nicholas, and it
so you know what to watch for.
Absolutely. So immediately I'm looking out for that, and then I would treat that as a medical emergency with a protocol in place.
Jane Ingham?
I'm cognizant of the fact that we've been talking mostly about the medical complications and the medical things we define as medical to watch out for, but there are certain psychological consequences and very practical issues that come up in these patients' lives that can be very urgent. And
such as?
I think that if a patient has debilitating anxiety, a depression that's coming on that might go unnoticed unless inquired about specifically by the GP, or very practical family issues that may be interfering with treatment, such as nobody to mind children so that you can't get to treatment and those sorts of things. They may need the person's in front of the GP, so a broad assessment by the GP, and I'm sure Tony would acknowledge the importance of this, of the impact of this illness as well as the medical things we're watching.
Not to mention financial impact and transportation costs.
Transport, especially in rural settings. So I think rural GPs are often very cognizant of those issues, and I think...
and even with regional cancer centres coming on, people are still going to have to travel to the regional cancer centre.
Very much, and someone might have to drive them or that sort of thing.
Let's go to our next case study, who's June, 69, lives in a town of about 8,000 people. She's married, her husband is still alive. She had early breast cancer about 7 years ago. She had a mastectomy and chemotherapy for node-positive breast cancer. She came to you 23 months ago complaining of fatigue and weight loss, and you referred her to Nicholas, where a CT scan found this. Let's have a look at her CT scan.
So this, in this case, does represent liver metastasis secondary to her breast cancer, although if that were the only abnormality that one found, you may require further investigation to determine the diagnosis. I guess
because it could be a hepatoma.
Because it could be something else. That's right. And I mean, the commonest presentation with liver metastasis would be the story that you just told us, but usually with multiple lesions rather than just the one. But assuming that the diagnosis is secure.
And you'd look for metastases elsewhere?
I would look, if that was all I saw, I would look for metastases elsewhere. But I, as Tony was, would be very suspicious that that's what it was, because she started out with a node-positive cancer a while back that obviously was thought at the time to be serious enough to merit adjuvant chemotherapy. So we know she's at significant risk of cancer recurrence.
So what would you do for someone like this woman, assuming that you're convinced that that is a...
So we're assuming that we've got the diagnosis right, and we're assuming, because there wasn't any discussion about endocrine therapy, that her original cancer was hormone receptor negative, so endocrine therapy is not going to be helpful. We would nowadays want to establish whether or not a HER2 test was done, because it may not have been done 7 or 8 years ago. It's done routinely on all breast cancers now. So that could be done on previous tissue, or it may already have been done. Assuming that it's hormone receptor negative and it's HER2 negative, then this is a situation where chemotherapy does come in. There's very good evidence that chemotherapy on balance will improve quality of life, get the cancer under control, and have a small beneficial effect on overall survival. So I would be talking to this woman about the meaning of this diagnosis, the fact that it was serious and potentially life-threatening, the fact that chemotherapy, although it has side effects, may well get the disease under control, and that if it doesn't, there's time for us to reassess other strategies.
And are these complex chemotherapy regimes that you give?
There is increasingly now a range of chemotherapies, and it would depend a little bit on factors like the pace of disease development, but we're talking about either the kind of chemotherapy that's given every week or every 3 weeks intravenously, so that means being close to a cancer centre, or potentially there are some oral chemotherapies that are effective as well and may allow easier treatment at a distance.
But it's going to be toxic to some extent.
It's potentially going to be toxic. It's going to require doctor visits, blood counts. It's going to significantly interfere with your life.
So she comes back in about 3 months' time, and here's the CT scan.
So this is, thankfully, relatively unusual. This is a devastating development. That is that despite what we presume, we intended to be effective chemotherapy, right at the beginning of her metastatic disease, she has substantially progressed, so that there's now very extensive disease throughout the liver. In general, as long as the woman is well enough and wants to pursue further options, you can usually find that with trying different chemotherapy, you may be able to get things under control for some time. But whether it's at the first time or the second time or the third time, at some point that is going to happen, and at some point we're going to need to have the discussion about whether further chemotherapy is really going to be helpful, and whether we need to concentrate on other aspects of managing the disease and how it affects her life.
And how unwell is she at this stage?
Well, she may not be that unwell.
Will she be in pain because of liver cancer?
She may be uncomfortable. She may be on regular analgesics because of liver capsule pain. And she probably is feeling a bit anorexic and off her food. I think one of the critical tests of whether it's a good idea to think about more chemotherapy or not has a lot of data behind it, but it's very commonsensical, and that is, how much time are you up and about? If most of the day or more than half the day you actually really need to be lying in bed, probably chemotherapy is not going to be terribly helpful, and you're not going to tolerate it very well. So that's quite a good, almost over the phone type assessment that one could make.
And Chris Milros, radiotherapy is not indicated unless there's a bony metastasis?
Unless there's a bony metastasis, or unless there are cerebral metastasis, and even then, related to what the elsewhere disease is doing and what the combined prognosis is from all of the locations.
And we should just talk about cerebral metastasis for a moment, because cerebral radiotherapy can knock you about a lot, can't it?
Cerebral metastases can knock you about even more. So, you know, if a person is symptomatic from their cerebral metastases and that person's elsewhere disease is such that, were the cerebral disease controlled, the person could expect a reasonable quality of life, then I think in that scenario, cerebral radiotherapy is almost always indicated. But in the context of a person who has advanced treatment refractory disease in multiple sites, whose elsewhere disease is going to progress, it's not unreasonable to have a discussion with the patient that says perhaps we shouldn't be treating your cerebral metastases.
I agree with that, and I think it's important to point out that as our systemic therapies evolve, they tend unfortunately to not get into the brain terribly well. So we are seeing weller and weller women with brain metastases, in which case radiotherapy is definitely indicated, but also the anaesthetics and surgery you know, has advanced over the last couple of decades. And so certainly one, but sometimes even two or three. If a woman is otherwise well and active, there's often a role for neurosurgery followed by radiotherapy.
So let's look at it through the lens of the palliative care physician. How should we be thinking about this woman now holistically?
I think holistically we should be thinking about this woman in terms of a spectrum of needs that she has. She has just received the news that the cancer has spread, that she has, we've got to that second scan, she's heard that the chemotherapy is not likely to offer useful benefit for her. So this woman's view of life, her priorities, her hope, everything's been turned upside down right now. And she's regrouping on how to find meaning, how to hope for what in this setting, as well as sometimes being troubled by physical symptoms, practical concerns about how to break this news to a family, how to sometimes share this with children as well as partners and friends. So there's a lot of needs. So the way of looking at it is, what are the woman's physical needs, psychological needs or concerns, informational concerns, practical concerns, and in the broader spectrum, in many instances, spiritual concerns.
And when you say spiritual, what do you mean? Are
well,
we talking
that's
about their
obviously
religious
very
belief?
different for every individual, the sorts of things that give them hope, meaning. It may be faith in some instances, it may be a broader concept, a different concept for other people. It's going to be different for every individual. But this woman's world has been turned upside down right now. And in terms of the palliative care needs and the I think that that spectrum of concerns clearly would not be addressed by one individual in a medical team.
Chris Keogh?
No, it certainly looks like it's a very multidisciplinary approach now. Even just simple things like fatigue management that might include having an occupational therapist come into the situation. Jane mentioned spiritual needs. There are some pastoral care workers around, but there's also local ministers and things like that as well. That may be a time when some counselling might be appropriate as well, when people are really challenged, I guess, by some of those...
But give me a sense of the transition to palliative care. Give me a sense of the sort of conversation that the GP should be having. Because GPs, you know, Tony's an exception. GPs, we've been singularly unsuccessful across Australia in engaging general practitioners in palliative care. Although they actually do it, they don't necessarily recognise they do it, but they're not involved as much as the palliative care people would like them to be involved, and certainly as much as our national planning would like it to be, for lots of different reasons, time, remuneration and so on. But let's assume the GP is making this transition to palliative, having this conversation, as they often will in a rural setting. What's the conversation they should be having with the woman?
Well, I think they need to be introducing the thought of palliative care. There are some women that actually choose not to take up that option. So sometimes it is good if it's coming from a variety of sources. So that might be the oncologist as well as the GP, or you know, even simply the community nurses, or whoever is taking care of that patient at the moment or at that time.
How do you handle it, Tony, that transition to palliative care?
Well, again, I think it's a really very individual discussion to have with that particular person, and often they have a partner or other family members with them. And you need to, again, put that in the context of your previous relationship with this person. You need to listen to what they would like. You need to make sure that they understand what you're offering with palliative care, that it's not that you're saying they're going to be dead within months, but this is really a program that can actually support both the person and their family over time. And often that becomes a really freeing discussion to have with people, and they engage in palliative care quite enthusiastically. And again, it's from a general practice point of view, I think it's really important that we actually make sure that we actually invite other members of the team.
And the key here, Jane, is that we tend to think of end-of-life care, the prejudice, not the prejudice, but the stereotypical approach to end-of-life care is that, you know, you're going to die in 3 weeks, whereas what we're talking about here could be a year or two, that this is end-of-life care, and there's all sorts of other things to consider as well.
Absolutely.
So it's about helping bringing in the appropriate array of experts to help that person have the best quality of life in the time that's ahead and minimise the burden for themselves and their family in this setting. I think the conversations can be difficult, and especially the beginnings of the conversations can be hard for patients themselves and for some GPs. It depends how much you've been taught in your training, and it used to be thought that breaking bad news was a skill you were born with. It is something that you can be trained in. It is something you can learn.
Chris Keogh, how much of your work is actually supporting the health professional to support the patient? In other words, that can be a pretty stressful thing and pretty upsetting. You're a country GP, you've known this woman for most of her life, you know her family, and this woman's dying, and you're the person who has to look after her. I mean, it's like a friend, looking after a friend.
It can be, and it often is, particularly for the GPs that might have an ongoing sort of relationship, and a lot of the community nurses that are providing that care are in the same situation. So I certainly do quite a bit of consulting to the smaller rural areas, and part of that is supporting them in looking after the clients, but also in educational needs, and there is also debriefing sessions that are available. The Cancer Care Network actually has a social worker that does outreach to some of those areas, and that's part of the role that she has as well in that debriefing and supporting of those health professionals.
Jane, anything else to add to that? It's just that you shouldn't be afraid to ask for some support if you feel you need it, if you're finding it upsetting and hard to deal with.
Absolutely. I mean, this can be really confronting, as Chris has said. Often these people are well known over a long period of time, and so it's not surprising perhaps that GPs and other health professionals might be quite affected. And peer support is really important, having discussions with your peers, whether you're a GP or another health professional, and of course there are resources available as well.
Yeah, I agree. I think that the health professionals involved, I think the more we engage as a team, the more we are comfortable sharing our concerns with each other, the better. But the only other thing that we haven't touched, or area we haven't touched on in a great deal here that I don't want to miss before we close, is the importance of the support of the family. And
indeed the husband or the partner.
Yes.
And in fact the NBOCC does actually have a booklet available for a resource for men, and so that they actually know how to deal or can feel some support and knowledge themselves.
And can I say, I listened to some of this in preparation for this, Norman, and I would really strongly recommend that GPs actually refer partners of women with secondary breast cancer to that resource. I found it a very useful resource to listen to, hearing men and women share their stories with some structured ideas about how to take it forward.
Chris Keogh, if a GP has only been used to referring to palliative care for the last few weeks of care rather than the last year of care, how different is it when the woman's still relatively well? Just give me a sense of, in an ideal world, what you do upstream from the terminal care.
Okay, so I suppose I should just clarify too that palliative care isn't only end-of-life care. That's a really important point to make. But early referral is always...
So on that point, it's symptom control, pain control. There's things you know about the drugs that perhaps other people haven't quite come to terms with.
Yeah, that's right. But early referral, particularly when some of these women are quite stable and quite well, it is about forming relationships, getting that trust with people at that early stage. And it is also about linking in with some of the other issues that they might need to be looking at if they've got young children, some of those things that they might need some planning and help with, partners, even just, you know, referring them to things like Centrelink for financial assistance.
And if there's nobody like you in the country town, what do you do?
Well, you know, the community nurses in country towns do have a lot of expertise in those areas, and they are actually, you know, working quite closely with these people and the GPs as well. Like, there is a real team happening there already. I just guess it's a bonus when you do have someone that has that expertise in palliative care. But to know that there are lots of resources out there as well that they can utilise.
Jane? That's the... When does the physician come in?
Well, the physician in terms of the GP doctor is there throughout the course of this illness and is
But I'm
crucial.
talking about somebody like you.
A specialist palliative care clinician can play a role when the needs are very complex, when the symptoms are very difficult or not easily controlled with those first-line strategies. And that physician may also assess a complex set of problems. So a patient who has multiple symptoms doesn't seem to be coping, things don't seem right. A GP may ask for that extra assessment. And so I think that we come in when things are difficult. That when things are difficult might be a different level for one GP versus another. And as we try to bring palliative care knowledge up in the nation, we are quite happy to be approached about simple things as well as complex things. There are resources, and in terms of knowledge resources, there's a marvellous resource in a website by the name of Care Search, which we'll also provide, which has an enormous array of resources for doctors about symptom control, evidence-based literature, etc., on various symptoms.
And what about end-of-life planning, such as what situations you want something done in, you know, in what resuscitation, treatment of infection, that sort of thing? Presumably that's an important part of this process.
That's an important part, to be sure that you're honouring the patient's wishes, because different people will have different wishes and different people have different hopes, some of which are realistic, some of which a conversation around them might help clarify. Again, this often happens in the GP's office with somebody who's known rather than with a stranger who's giving an expert opinion, but especially in the country setting. But I defer a little to Tony to answer some of those questions.
Sure.
They're absolutely crucial to.
Sure. Again, I think this can be a really very useful thing for the woman and her family, having that conversation around an advanced care directive, having a conversation about where she might like to die, in the home, in the local hospital, in a palliative care setting, for instance. Making sure you've got flexibility around that, because certainly in my experience people do change their minds, and you need to be flexible and sensible about this. Talking about things that you would offer them, such as interventions. Talking about the funeral, for instance, and that may happen as part of the conversation with the broader palliative care team as well. But certainly doing this proactively, I think, is a really good thing, and it's good not only for the patient but also for their family, and certainly for the health professionals that are involved.
Do you go to the funeral?
I have. I don't go to all my patients' funerals, to be honest, but I certainly have been to patients' funerals, not only people that have died from cancer but from other causes as well.
Chris, what about after the woman has died? What's the role of bereavement counselling? Because some people say it's overdone. You know, it's forced on people when they might not need it or want it.
Well, not everybody needs bereavement counselling. I think it's important to know that, you know, grief is a normal expression that people have after someone that they love or care for has actually died. So we would always contact people after someone has died and make sure that they know that we're available if they need that ongoing support as well. Same as Tony, I don't always attend funerals, but in some cases, if it's been a long-term client or the family have formed a really close relationship with you, that might be a time when you might do that as well. It may not always be appropriate for, say, me personally to contact people after someone has died. It may be someone else in the team as well, you know, if someone's had a close contact with them, such as, you know, even an OT, physio or something like that. So just so that they've got that ongoing link. We also give out information regarding the Cancer Council's bereavement support group and, you know, other brochures. There are other groups that are run around, like some program called Seasons for Growth, which deals with grief and bereavement in children and adults. And, you know, open and honest communication about death and dying within that family unit is always really important, and to try to get that sort of information across to them, particularly when it's children that are involved as well.
Look, thank you all very much indeed. It's been a difficult subject, but you've been, the information is important, and I just wondered what your take-home messages were for the audience. Nicholas?
I think the two things from my perspective would be for GP and other healthcare professionals in the country to realise that metastatic breast cancer is an extraordinarily heterogeneous disease, and as we've seen from our two cases, situations where a woman may be very well with metastatic disease for many, many years, other situations where she may rapidly become unwell and have a lot of symptoms that need to be dealt with. And the second thing is, although we did discuss a couple of, if you like, danger flags in need of urgent attention, like suspected spinal cord compression or sepsis in a patient on chemotherapy, predominantly developments, either the new development of metastatic disease or progression of known metastatic disease, is not an urgent problem and tends to evolve, you know, over weeks or months rather than hours or days.
Chris Milros?
In addition to the fact that Nick's already mentioned, namely that not all metastatic breast cancer is exactly the same, I'd like to emphasise the importance of communication between the clinicians involved in the care of the patient, you know, in recognition of the fact that local problems will frequently benefit from a local treatment such as radiotherapy. Systemic problems will benefit from a systemic approach to the problem, and it's really only if we talk to each other that we'll establish what treatment's appropriate for what patient.
Chris Keogh?
Early referral to palliative care services, that helps to build, you know, form those relationships and build trust, and it's the same with the palliative care team, to be collaborative and, you know, probably communication, really, keep that trust and develop relationships to provide quality care.
Jane Ingham?
Well, I think as a message to doctors, I think the message is that we have a patient in front of us who's often come to us. It's important for us to embark upon a broad assessment that looks at them, the individual, more than medically, so that we can, and we, including GPs, can refer appropriately, make sure this person's got the right multidisciplinary team around them to address the spectrum of concerns that they may have. Pain and symptom management is a crucial part of the doctor's role, and one must know one's own spectrum of skills, have a reasonable armamentarium for the first pass, and know where to turn for help if there's extra help needed for symptom management, and know that most palliative care clinicians would be quite happy to, would welcome a call or a conversation, even if, and most areas have a palliative care clinician linked somehow with them.
Tony Hobbs?
Look, I certainly endorse all of those really strongly. I think the GP has a really central role here in diagnosing and help to manage, and not only managing physical problems, that is the cancer, but the psychological response to that.
Look, thank you all very much indeed. And I hope you've got a lot from the programme as well, this programme on secondary breast cancer. Our thanks to the National Breast and Ovarian Cancer Centre for making the programme possible, but thanks also to you for taking the time to attend. And if you're interested in obtaining more information about the issues or resources talked about in this programme, there are a number available on the NBOCC website. That's nbocc.org.au. And of course on the Rural Health Education Foundation website, that's rhef.com.au. Don't forget to complete and send in your normal evaluation forms to register for CPD points. And also please check the RHEF website for the special post-knowledge survey. I'm Norman Swan. Good night.